Good morning, everybody. Thank you for being here. We have a really exciting conversation on an important topic about the opioid crisis and stigma. I'm joined with a great panel. Right to my left, we have Dr. Kelly Clark. She is the immediate past president of the American Society of Addiction Medicine, and she also founded Addiction Crisis Solutions. To her left is Gary Mendel, who is the founder of Shatterproof, a nonprofit working on the opioid crisis. To his left, we have Dr. Andrei Ostrovsky. He is the former chief medical officer of the US Medicaid program. He's now working as an investor in various health startups, some of which are dealing with opioid crisis. And then to his left, we have Dr. Nora Volkov. She's the director of the National Institute on Drug Abuse at the National Institutes of Health. And sort of to set the stage for the conversation, I was reading a post that Gary wrote, and I think it really kind of gets us in the mind frame of what we're talking about here. His son committed suicide after suffering from a substance use disorder, but Gary writes that it was not addiction that took his son's life. His son wrote, it was about not being treated like a human, especially one who has worked so hard to get back to normal. And in this piece, Gary quotes the current Surgeon General, Jerome Adams, who says, "Folks often ask me what the biggest killer is out there. I think the biggest killer out there is stigma. Stigma keeps people in the shadows. It keeps people from coming forward and asking for help. Stigma keeps families from admitting that there is a problem." I think that kind of gets us in the mind frame of what we're going to talk about here. And maybe since you're sitting right to my left, I'll start with you, Dr. Clark. Can you give us a little bit of an overview of how stigma impacts both who gets treatment and also how they are treated for opioids and substance use disorders?
Well, that's a great question. And I'm going to start by just saying my definition of stigma is that stigma is just discrimination and prejudice. It is judging a person based on something about them that we consider negative. And addiction itself, addiction is a chronic brain disease. And we know that brain diseases always involved stigma. In the US, we really no longer consider that epilepsy is caused by demonic possession. We used to, and that's still true in parts of the world. But brain diseases kind of scare us. They involve behavior, they involve, they're kind of scary. We don't know what a person's going to do. Maybe we could catch it. There's something around brain diseases, and addiction itself is a chronic brain disease. The problem is that we have a whole treatment system that grew up outside of that was based not on medical care. But if we think about addiction as this chronic brain disease, what does that mean? That means, consider the term, any sentence that you can come up with. If you can't take the word addiction out of it and put the word diabetes or epilepsy into it, then you should reconsider that sentence. So just to frame this up, for example, imagine a person who's not taking care of their diabetes and they're in and out of the hospital with really high blood sugars. And then they come out, and they come into the hospital, and we put them in for 3 days to normalize their sugar. We send them away for a month to learn how to diet and exercise. We discharge them without insulin, and they come back into the emergency room. And do we blame them for not being able to control their diabetes? No. So say they start managing their diabetes, and they're doing well, and they're not in the hospital, right? And then say they go to a party, and they have a beer and a cupcake. This is not on their treatment plan. They're not adherent to their treatment plan. Do we then say they failed their treatment and they need to go back and see an endocrinologist? No. Do we try to cure a chronic disease? No, that's the nature of chronic. And certainly Dr. Volkov is the expert here talking about the brain changes that happen with addictive disease. So what's the goal in treating addiction? It's the same as any chronic disease. Decrease the disease-related risks of dying early. Stay alive. Get healthy. Decrease all of the other health problems that happen. Get back to work. Start functioning again and decrease the total costs of care. If we consider and approach treating addiction the same way we do with any other disease, then things will make sense. The problem with our access to treatment is we haven't built a structure that is that kind of evidence-based, doctor-led, requiring quality of care.
Dr. Volkov, when we talked a bit about stigma yesterday, you mentioned that there's not just stigma around people who are suffering from addictions, there's become different levels of stigma depending on exactly perhaps how your addiction developed or what your particular addiction is related to. Can you talk a little bit about that, that we're not just dealing with this one sort of crisis of stigma, there's different levels depending on.
Yeah, no, and this relates very much to the stigma that emerges in right now that is very obvious with the opioid crisis, where we have started to recognize people that become addicted to what's so-called no fault of their own, as if the others had fault of their own, because they were prescribed an opioid and then they become addicted. And I've heard this phrase that says, but those are different from the other addicted people. So we are generating two groups of addicted people, those that are actually look like us, that actually go to the doctor, that they are given prescribed, they believe in their doctors, and then they become addicted. And then those on the other side, which were still terribly stigmatizing on the notion that this is a voluntary behavior, without a recognition that for us to exert voluntary behavior, we need to actually be able to make a decision and carry it through. And for us to be able to make a decision and carry it through, we require the function of the brain. And if those areas of the brain engage in our capacity to self-regulate ourselves and not functioning properly, that whole notion that it is a voluntary action becomes irrelevant. And I think that that's what's so very difficult. And I think a lot about why do we continue to stigmatize addiction? Why do, even though the data show and we can demonstrate where the damage are in the brain and how that helps us understand the behaviors that are disrupted, why has it been so extraordinarily difficult to not make people say it's a disease, but to embrace the concept and change the structure that we have in order that we treat addiction as a disease, not just say it's a disease, we treat it. And I think part of the difficulty relates on the fact that we as human beings learn from our own experiences. So we are used to being able to regulate our actions, and therefore we assume that everybody else has the same capacity. Yes, this is very, very myopic. It's like me saying, okay, look at this marathon runner. If he can do it, I can do it. Each one of us has different capabilities and different environments that may lead you to greater or less risks or resilience. And in the case of addiction, one of the key components in the brain that is actually affected from the use of drugs or from being in very stressful environments is the prefrontal area of our brains. And that's the brain area that is able to direct connections into our limbic brain to regulate our desires and our emotions. It's actually the one that leads us to say, wait a second, this is not a good idea, I better not do it. And once you make that decision, you don't do it. If that area is not functioning, you cannot actually generate that behavior. And I always use that metaphor because it's so simple and it's so, in many ways, reflects it. It's driving a car without brakes. You may want to stop. If you don't have any brakes, you're not going to be able to do it. And that inability to put yourself in someone else's perspective as opposed to your own, I think is one of the big problems that we have with the stigmatization. And it's not just in the healthcare system. I even see it in families, where the families themselves get to a point that they no longer tolerate the person that is addicted. And so you isolate that individual furthermore. So it's the stigma in general to addiction, and now we're generating a second stigma related to the difference between people that become addicted because they're prescribed opioids versus those that become addicted because of other reasons.
Gary, your organization is going to soon be launching a big project on stigma. One of the things I'm curious for you to share with our audience is how you guys have come up with or researched ways to actually attack stigma. I think it's easy for people to visualize scientific solutions to processes, a drug to treat a disease, a medical procedure, surgery. But where did you go to sort of learn how can we actually cure stigma or treat stigma as we address this opioid crisis?
Sure. It's a great question. Dr. Volkrow and Kelly provided a good understanding of what stigma is. But I think the first question is how relevant is it? How much resources should we spend toward it? Do we pour money into treatment? Do we pour money into prevention? Do we pour money into other things? Yes, yes, and yes. But does the stigma, even though we've described it really well, and it's unjust and it's unfair, is it worth, why did we spend time getting involved with it? Well, which is going to lead into the answer to your question. I made a call to a partner at McKinsey & Company in February and said, look, we have a 5-point plan to really improve the treatment system in the United States. One national standard of care, quality measurement system, payment reform, professional training, and stigma. And we're working on 4 of the 5. But stigma, we nor anybody else is working on in a comprehensive way. And I believe it should be. I've identified 9 drivers of the opioid epidemic. Overprescribing, increase of fentanyl and heroin, on and on and on and on. 7 of the 9 are driven by stigma. And if you look at our nation's response, $8 billion by the federal government currently in 2018 and 19, not a penny is directly attributed to attacking stigma. 7 of the 9 drivers, and we're not attacking it. You know, so McKinsey, would you put a team of people on this for 3 or 4 months and study what worked for HIV/AIDS? How did we change our view as a society? What worked for marriage equality? What worked for domestic violence? How did we reduce teen smoking so significantly? It wasn't a stigma, but it was a social change. And they agreed on a pro bono basis to do this for 4 months. And in answer to your question, what did we learn? We discovered in those social movements there were about a dozen key success factors that they struggled for decades, each of those, until they found the right formula. And we narrowed it down to 7 that we believe will be most relevant to reducing stigma related to addiction. And it's so important because it's 7 of the 9 drivers. So what are those 7 in answer to your question? I won't go through each of them, but give you a flavor of it. Number 1, one central coordinating organization to bring the country together for this initiative, like the Tobacco-Free Kids did for smoking, freedom to marry for marriage equality. Number 1. Number 2, action items were actually low cost for many stakeholders, and they were in 3 areas: educating, policy changes, and in some cases, change in language, which we think are really relevant to this disease. Number 3, what type of education? Well, if you're in middle school and you haven't formed your opinion yet, language in words and in content like educational material works. But once your opinion is formed, high school or later, it needs to be in stories. It needs to be in stories that 2 things come across, either both in the same story or separately. And this is the key thing. It needs to humanize it and get away from them to us. And secondly, that treatment is effective. Evidence-based treatment is effective. And if those 2 messages come across, you can change the way that people think. Just as an example, before I go on to the others, and I'll stop for there, is Dr. Volkrow both talked about the discrimination and about how it's either their fault or not their fault. In a recent poll, 44% of Americans said it's their fault, they're not trying hard enough. Roughly half the country. And half the country said it's not their fault, they developed a chronic illness. To me, that's not that relevant, whose fault it is. What's really relevant to me, it doesn't matter to me, the research shows that's not that relevant. What's really relevant is 80% of Americans said, it doesn't matter whose fault it is, I am not willing to associate with someone as a friend a coworker, or a neighbor. Why did my son take his life? He was successfully treated. He hadn't used a substance in 13 months, but he lived in a society where he didn't read some survey. He felt and lived that survey. And it's not my son, it's millions of Americans, whether it's opioids or alcohol, feeling like you can't, no one wants to be your friend, your coworker, neighbor. Date your daughter, date your son, be in the same Little League team, or coach a soccer team with your son or daughter. It's not Little League, they're too young, but that's, you get my point. And if you have every company in America sharing stories once a year, twice a year, where someone gets on a webcast for 15 minutes a year or twice a year at a company and says, hi, I work for this major company or any company like all of you. I've been here 10 years. I've been promoted 3 times. I'm married with 3 kids. I coach Little League. I go to church on Sunday mornings with my family. And I'm addicted to heroin for the last 4 years. And 10 of you on this call, I play tennis with every Tuesday night. And you didn't know. And 3 of you on this call, I carpool with every morning. We live in the same neighborhood. You never knew. We have neighborhood barbecues. 200 of you on this call, I've been working in the same office on the same floor for the last 5 years. You didn't know. I got promoted 4 times. That's what addiction looks like when treated with evidence-based treatment. That's what worked with marriage equality. That's what worked with HIV/AIDS. That's what will work with this. And it costs $0 for a company to do that. If we hand them a prototype of a toolkit with 3 different ways to share your stories, pick the one you're most comfortable with.
Dr. Ostrovsky, somebody who worked at the Centers for Medicare and Medicaid Services that has a lot of influence on how our public policy could perhaps impact stigma. What do you see as the places where public policy may be contributing to stigma, and where are sort of the paths in where public policy could actually help change where we're going now and ensure that stigma isn't a factor in terms of people getting the treatment they need and the help they need, and public perception as well?
There are policy vehicles that we certainly can change, eliminating X waiver, investing more in education of providers, and there are several other examples. But the current policy framework isn't in and of itself the rate-limiting step in overcoming stigma. It really comes down to a lot of what Gary described. It's making sure that leaders, decision makers, and everyday people change their frame of reference when they view substance use disorder from judging an individual to looking at substance use disorder as a chronic disease. I'll share one example where amongst providers, there is massive stigma. I'm a pediatrician clinically, but I, as a clinician, should know how to identify someone with mental health issues or how to identify someone with substance use disorder issues. And I failed to do that. I had an uncle who passed away, an uncle that I judged for over a decade. It's an uncle I highly respected and loved as a little kid. He was the uncle that got me the T-shirt from Jamaica that said, see no evil, hear no evil, speak no evil, shit happens, man. And I wore that in 7th grade, and I was, felt so cool. And he was like, yeah. And I love this guy. And then, my dad continued to provide for the family. He had a marriage that fell apart. He was estranged by his family, never saw his daughter, couldn't hold down a job. And I thought to myself, what's this screw up doing? And distanced myself from him because I judged him. All the while I'm going through medical school, residency, somewhat learning, not really being taught effectively to look for substance use disorder or to think more thoughtfully about the whole person, but I should have known better. And then he died. And we didn't know why he died. It was quite very, under wraps. No one wanted to talk about it. But we ended up doing some digging and learned autopsy reports and learned there were opiates in the system. And then I ended up meeting with his roommate and best friend and learning they had together multiple substance use disorders at least for a decade. So all the while I was judging him, instead of reaching out and sitting down and asking, hey, how are you doing? How are things? What's going on with work? What's going on with family? And instead of listening, I judged him. And I'm a provider, and I supposedly am a policy expert on this stuff. I should have known better. So if I, in the middle of trying to change policy, trying to change systems, trying to invest in companies, trying to do all this change, missed it, how do we expect average Joe Schmo who doesn't necessarily know the literature on evidence-based treatment to also get it? I think part of it is we see at sporting events a very proud pink shirt, pink jersey with a bow celebrating, yay, let's fight cancer. Why aren't we doing that for addiction? We're not celebrating, as Gary pointed out, we're not celebrating when people are getting into recovery. There's still policy work to be done, but even if there's no policy change moving forward, it's a societal change. It's what Shatterproof is doing, I think, is critical to have a coordinating body, bring all the major players together, and in a consistent way, ensure that we're making forward progress in the same way. And I'll also share, again, from the provider perspective, I've interacted with a lot of my counterparts, chief medical officers in various settings, health plans, chief medical officers of state Medicaid programs. I've literally continued to hear the notion that, oh, well, we have to be careful giving all that buprenorphine because they're just going to divert it. They're just going to sell it on the street. With this chief medical officer not taking a step back and thinking, why is it that buprenorphine diversion happens? Well, it's because you can't get access to treatment and you're in withdrawal symptoms and you're waking up and the first thing you're thinking of is not, am I hungry? Is not, do I have a roof over my head? It's, I'm going to have this awful, worst flu-like symptoms I could ever have, withdrawal, if I don't get some kind of opiate in my system. It's not because someone wants to go party, it's because they don't want to feel like they're dying. And so when a provider is thinking, oh, these are patients, they're just trying to game the system, they are gaming the system because the system's broken because you as the chief medical officer have not authorized sufficient reimbursement for buprenorphine or methadone or other evidence-based treatments, naltrexone. And that's the problem. We need to get leaders to do what I did, hopefully not with someone dying in their family, to help them realize it. We need to realize it's a chronic brain disease. There are evidence-based treatments. There are ways to solve this, and certainly policy mechanisms can help. Like, let's get rid of the X waiver, and that's one small drop in the bucket.
What is the X waiver?
Oh, it's the buprenorphine. So if I wanted to, so today I can prescribe any one of you morphine, methadone, oxycodone if it's for pain. Even as a pediatrician, I can write the script right now. If I wanted to write a script for buprenorphine,
which treats someone addicted,
treat someone with opioid-use disorder, I would have to go do a training, which is fine. Certainly that training could be helpful, but there are a lot of logistical roadblocks for me to go do that training, get that approval, and then even with that, I can only treat a couple hundred patients at any given time.
But can I interject? Because I think that here is we're also seeing the notion of stigma. And in general, we say, okay, one of the roadblocks is the fact that you have to take this course. But the course is not such a big deal. And the reality is that there are many physicians that have been waived that are not actually treating their patients. So where I see the stigma is the reimbursement level that is necessary is not incentivizing those physicians to provide the buprenorphine. So there is an element, and discussing it in terms of there is stigma for the disease, but there's also stigma on the way we treat it, and there's stigma for the medications. So the wavering, one can make one argument or the other, because my perspective also is we ended up in this opioid crisis because we became overconfident that we knew how to prescribe opioid medications, and we were not properly trained. So my perspective is let's not replicate what we have already done and create a system that will enable physicians to properly prescribe buprenorphine and be reimbursed for those services at the same level that we do other medical conditions, not stigmatize it, and understand what is the optimal training that a person needs to avoid the horrible crisis that we did for not properly treated physicians on the management of pain. And I also think that another aspect, because I mean, I'm obsessed about it, obviously, since we have the data and we have the evidence and things are not changing or changing very slowly. In terms of policy, Andrew, one of the areas that I think would be very valuable is policy that relates to the justice setting. Because if we continue to criminalize people that are addicted, that is a major mark of stigma. Because people that end up in prison or jail are considered the most stigmatized of all of them, because we associate them with them doing something that is criminal behavior. And so policy that actually changes the perspective of dealing with addiction as a disease as opposed to the criminal, I think could be very valuable as one of the interventions, because I agree with you, it's much more than just policy.
And I would go, so I would
ahead,
just
ahead.
take that and move that forward and say, so here's the study. Informed consent, risk, benefits, and alternatives of treatment. They did this with people in Rhode Island who had opioid use disorder that were leaving incarceration. And 2/3 of them chose methadone, one of the 3 medications. 1/3 chose buprenorphine. And about 1% chose a monthly shot of another medication, extended release naltrexone. The death rate in the 6 months after they left incarceration with that, as opposed to a control group the year before, decreased so much the entire overdose rate in the state decreased. We have this issue with medication-assisted treatment, okay? Back to my statement. If you can't use diabetes or epilepsy in the statement, does insulin assist the treatment of diabetes? No, that's stigmatizing language. You don't talk your way out of a chronic brain disease. Can you imagine a psychiatric hospital where a person comes in who has schizophrenia, and they're hearing the voice of the devil telling them to kill someone, and that psychiatric hospital doesn't believe in medication, as though it were the Easter Bunny, and doesn't give them medication? Would that hospital be licensed by the state? Would any health plan pay for treatment at that facility? And that used to happen until a court case, Osheroff versus Chestnut Lodge. And now there's a duty to treat with evidence-based treatment throughout medicine, but somehow not yet with addictive disease. We know that 60% of the treatment facilities in the country don't utilize medication to treat OUD, and that's what people are paying for.
And the difference in what happened in Rhode Island, was it that the people leaving prison were allowed to, or were given an opportunity for treatment for their addiction, or was it that they were given the opportunity to pick which of the treatment options were best for them?
They picked medications, and then they were allowed to stay on those medications.
Okay.
Because we know the medications save lives. It doesn't assist treatment.
So you want to talk about another policy change? People who go into who are on Medicaid, who are put into the prison system versus the healthcare system, lose their Medicaid. So now they have to get out of prison and reapply. And during that time period when they're reapplying, many don't, but those that do, they're not getting treated. Which is, anyway, let me switch this for a second. We talked about issues, and we all have them, and you can see how passionate we can go on for hours without, you could just sit and listen, right? But the good news is, for all of us, we have evidence of how this was changed with HIV/AIDS, with marriage equality, with smoking for teens, which dropped from 25% to 5%. This is not taking someone to the moon. It really isn't. This is blocking and tackling of 6 key things. And we started to talk about some of them. But in our plan, we have worked on this with McKinsey for the last 5 months now, and targeted 4 systems for change. Employers, 4 easy action items, doesn't cost a penny for every employer in the country. 2, healthcare system. 3, criminal justice system. 4, media and entertainment, the words we used, the storylines in all the shows and documentaries and movies that are put out. Are we depicting people as constantly relapsing and breaking into their neighbor's house to steal something? Or are we depicting people in successful recovery? This is blocking and tackling. Local communities need to be from grassroots up. We have action items for different sectors of local communities, from faith-based to all the different subsectors within communities. Do these 3 things, things will change. This is not, again, I'll say it 100 times, this is not taking somebody to the moon. This is not doing the difficult work that Nora does to come up with new medications. I'll give you another policy change. Nora's budget is about $1.4 billion a year. Why is Nora's at National Institute of Drug Abuse? Why is it $1.4 billion a year when cancer is like $7 billion?
$1.25 billion.
Excuse me?
It's $1.25 billion.
$1.25 billion.
So if I have 1/4, I'll be very happy.
So $1.25 billion, when cancer, when heart is $4 billion and cancer is $7 billion, even though twice as many people in this country have a substance use disorder than someone who has cancer. And I'm not taking away from cancer at all. That should stay at $7 billion. And why? I'll even tell you even something worse. Look, I'm not speaking out of turn. It's well known Nora is one of the most brilliant people on this planet related to what she's doing, if not the most brilliant, has produced all this great science. What we just heard is less than 40% of the treatment programs in this country offer one of the 3 medications that Nora spends $1.2 billion a year creating. So the money's used well. We have medications. We have the science that shows it works. And then we have a healthcare system where the Surgeon General says, and which is Nora's research, that every patient should be offered all 3 and choose the one most appropriate for them. And 40%, only 40% offer even one, 2% offer all 3.
Dr. Clark, you're doing some work with employers in this country to try and change that. Can you talk a little bit about how you're working with employers who provide for many people their health insurance programs to make sure that people are getting the proper options for addiction treatment and making sure they are getting accredited options? And then again, how stigma has impacted what's currently available versus what should be available scientifically and medically for these people?
Absolutely. So when you talk to companies, they know that they've got a problem with substance use disorder and mental health issues, and they know they've got a problem with alcohol, which is really responsible for about 1 out of 20 cancers in this country, is alcohol use. But the opioid use problem, they're less sure how to deal with. And what I try to do with these employers is to help them to understand that they're the purchasers of healthcare, and the health plans work for them. And what they need to ask of those health plans are, what is your real network of addiction treatment providers? Do you have board-certified addiction doctors in your network? What kind of access do you have in your network to medications for addiction treatment, for opioid use disorders? Is it a phantom network? Is it a real network? How many people leaving a treatment program are on an ongoing medication? Because those are the metrics you need to know, is your health plan actually paying for care that's helpful, or that's either useless or harmful? Because those overdose rates go up when people leave incarceration. Also, when they leave a detox and rehab 28 days, if they leave and they're not on a medicine, their risks of overdosing and dying within 3 months are higher than if they had not completed that 28-day rehab, right? So they need to understand what they need to be paying for and not paying for. And they also need to put together, so this is back to stigma, exactly the same way you're going to do this for medical care. Standards of care, and the doctors have determined standards of care. But also in HR policies, because there we have stigma as well. I hear from employers saying, well, for return to work, we want to make sure the person's not going to use again. That's like saying a person can only return to work if they're not going to have a seizure again. That's not reasonable. That's not how we deal with a chronic disease. So if you take that construct, and really there's that general construct of, does it work for another medical disease, chronic medical disease, and think about it in terms of addiction, that I think helps them change their minds. I would point out one resource that's out there. Our our employer community in Louisville, greater Louisville area is called Kentuckiana. The Kentuckiana Healthcare Collaborative put together an employer toolkit that I helped with that addresses some of these, and it's free. It's on their website. So if people are interested, just a resource you can have.
You look like you're itching to jump in.
I want to point out something where there's a really big opportunity to infuse the guidance that Shatterproof is pulling together around stigma reduction and to incorporate it into what is the supply chain of selling employer-based health insurance. There are large health plans in the country that often will use a broker. The account rep for the health plan or the broker that is introducing that health plan to an employer are not clinical people. The people at the employer that make a decision of which insurer to pick are not clinical people. We have evolved over the last couple of decades where there are actual medical teams, providers at an employer. Now it's a few people that are not clinical in any way. They're given a budget and they say, here, go fit a plan that allows for the most flexibility for our members because we want to retain these employees. We have a pretty big opportunity. If we can go to the WTW, the brokers, if we can go to the large health plans that sell to employers, the ASOs, the Aetnas of the world, and if we go to, at the employer level, the actual purchasers of health plans and say, what you have been doing to date is not informed by evidence in any way. If you can't afford to get a clinician to help you out here, okay, but here's a framework of how to at least eliminate stigma in how you're deciding on which chronic condition programs you're going to be reimbursing. I think that's a pretty big opportunity. The other thing I want to point out, which relates to this, it also relates to the media aspect of things. There's a study out of the Stigma Lab at Hopkins that reviewed what framing and messaging around addiction will lead to more or less stigma amongst the general population and positive or negative policy change. And there's a very interesting nuance where if we tell stories about people getting into recovery, and those personal stories will both improve stigma, decrease it, and lead to positive policy change. If we tell stories of people that are getting into recovery and how there's criminal justice implications, like less crime, that, the research shows, improves the policy landscape, but actually also worsens stigma. So there is a ton of nuance that, and there's research to guide us on how to tell these stories. But if we are going to go to Netflix and their procurement department of which new shows they're going to fund, or Amazon Prime, or whatever, whatever the decision makers are that fund and determine storylines, we need to incorporate that research. And I think we need to incorporate that research into the supply chain for health insurance. I think we need to incorporate that research into how we're framing our policy discussions. It's that level of nuance that ultimately, as long as we're consistently going back to that research and not using stigmatizing language and being very candid about the reality of this chronic brain disease, I think that's how we slowly make a difference around stigma.
And you know, I wanted to interject a point because one of the things that we all have said at one point or the other is, look at what happened with HIV, which was highly, highly stigmatized, and over a period of very short time, it basically was destigmatized, and what was possible was that there was a very strong movement that actually led to the development of multiple antiretroviral treatments that actually solved and treated that condition very rapidly. And we have not had that kind of investment in addiction. And I think that there is an element, though, that is different, perhaps for some of the mental illness, but more so than other medical diseases. And actually, Andrew opened up my eyes to it. He was directing a methadone clinic, and I had said, Andrew, invite me. I invited myself to his clinic, and he says, can you help me speak with people that are addicted, to ask them the question, what is it that me as a research agency can do to help you stay in treatment? And so he gathered 6 or 7 people in Baltimore, methadone clinic, and each one of them said, my one priority why I cannot be on treatment is I'm homeless. And so I came back and I said, what are the difficulties that these people have in order to actually access treatment? If they don't have a place to sleep, they cannot be thinking proactively of where they are going to go. Now, advance that, and 2 months ago, I was in Kensington, Philadelphia, which is the center of the heroin crisis on the United States, and I went to see Prevention First, which is a treatment program that also provides syringe exchange program and HIV referrals. And what they said to me, and it was extraordinary, the devotion of these people, he says, we do very poorly. We actually, our patients relapse very high. Why? Because the social economical deprivation of these individuals is devastating. And when I was hearing Gary's story of his son, he said something that goes not necessarily always with the socioeconomical challenges that they have, but it's as profoundly disturbing: loneliness and isolation. And loneliness and isolation promotes stigmatization. It's someone that is separate, but it actually makes it so much harder for the person that's addicted. So as we're discussing the issue of stigma, in my brain, we're going to need to address the need to bring social structural systems that are meaningful for these people, and that we can feel empathy for them, that we can feel an emotion of what it is to be addicted to a drug, just like we feel with someone that has Alzheimer's or cancer. We need to generate that narrative, because I think that ultimately will lead people to be compassionate.
A couple of people have mentioned HIV and AIDS and other areas where society has made progress in reducing stigma. But this spring, I actually, because the president has sort of reinvigorated the effort to deal with HIV and AIDS this summer, I went to South Carolina to areas where there still is a lot of stigma around HIV and AIDS. And I was personally pretty shocked when you meet people who say their doctors use discriminatory language around them to the point where they didn't feel comfortable seeing the doctors. You talk to people that don't actually realize the amazing treatments that have been developed for the disease, who think it's still a death sentence. They don't quite understand how you can and can't get it, so people are afraid of others with the disease, even though it's not a communicable disease, and that sitting next to somebody or touching them can get you. So how do we make sure with the opioid crisis as we move forward that we address stigma in a way that's holistic, that we don't leave communities out? Because it seems like there are huge pockets of the United States where mindsets have been shifted and people do feel comfortable in a different way getting treatment for the disease. And then there are also pockets that have been left behind where the stigma is still just as much of a problem as it was in the 80s.
I'll start out, but I'm sure that we have all opinions on that. Again, coming back to, we have spent the last now almost 6 months developing this plan, and we've prioritized 6 systems in the country. So it's comprehensive, but it's not complete. We focus on the 6 systems that we think can have, we strongly believe will have outsized impact in reducing stigma. Employers. There's 130 million people in this country that are employed, so it's a great distribution channel to change hearts and minds, knowledge, attitudes, and behaviors. If knowledge is distributed in the right way, through evidence-based ways of delivering it, attitudes change and behaviors change. So to employers, and by the way, even though there's 6 million employers with 130 million employees, there are our 1,000 largest companies in the United States are 30 million of those employees. So we're just 1,000 companies. We can educate in a way that's changing the attitudes and the behaviors of 30 million people, and those large employers will have influence in bringing in many of the others. So employers, healthcare systems. Somebody here, I think it was Nora or Andre mentioned, or you did actually, the language that providers, Sarah, it's what you said, the language that people feel in the healthcare system, the respect or disrespect they feel when they're getting treated. So that's the healthcare industry. 3, criminal justice system. We've talked about that in spades. Media entertainment, the language we use and the stories we portray. Local and state and federal government, certain policies. And then 5 is local communities. So to answer to your question, action items, 5 things we need every stakeholder in each of those systems to do. Make it simple. Let's walk before we run. Each of you do these 5 things at almost or little or no cost. Within those 6 systems will create change. I spent a lot of time with Bill Novelli, who led Tobacco-Free Kids. And there's one sentence I pulled out of the 3 interviews we had with him that's really stuck with me. A turning point in the tobacco movement was getting faith-based communities involved, local communities. So I think in answer to your question, comprehensive, 6 systems, easy to do action items by every stakeholders or actors in each of those 6 systems, and getting mass adoption of 3 to 5 easy to do things, it will move it, there's no question.
In a minute or two, I'm going to go to audience questions. So while you guys are thinking that, I'm going to ask Dr. Volkov one more question. Gary wants to give you a big budget boost. So assuming he was able to do that, you guys wave your magic wand. Where would you invest that money and research around this issue of stigma and addiction?
Well, we are very interested actually.
Can I just clarify one thing? That budget doesn't have to be all directed towards stigma of addiction. So I just want to clarify that. Sure. But the spending on this issue is because of stigma. We're only spending $1.25 billion when we're spending so much more in other diseases.
Yeah, no, but I do believe that overall research on stigma has been neglected, and I think that forums like this one are very important to communicate areas where there are gap areas. So we're very interested actually on building up that portfolio, but one of the things that I would like to do as the first step towards that is to bring the patients and their families so I can hear from them what is it that it means for them to be stigmatized, and how would what would advance decreasing the stigma? Because one of the big challenges that we have in stigma that again is sort of different perhaps in obesity from other diseases, obesity and addiction, is that the person has internalized the stigma. Their own self-depreciation is gigantic. And we need to start also by modifying the stigma that the person that's addicted has toward their own disease. And so we want to bring them actually together and then learn and ask researchers to come up with proposals about what is the best strategy. I do believe that language is fundamental because we reify things the way that we name them, and that becomes reality. I like very much your concept of using media, because through media we hear stories, we feel the stories. We need to make people feel what it is to be actually devastated by addiction. That will generate, I think, that response. So build up the research. But if we had more money, of course, we wouldn't use it all for stigma, but I do recognize that that is a gap area. Another gap area that I've been very much voicing that we need to tackle is that because the states are coming up with policy, local policy things on how they manage treatments in prison systems or in the communities or in the healthcare. How do they work? What are the results? So research on what policies that states and local municipalities are doing that can actually enable us to understand what works or not. I also think that there's another tremendous opportunity, an area that has been somewhat neglected, that if I had more money, I would definitively accelerate, is recovery. So we're speaking about, and actually sort of someone says, well, we are doing all of this research on treatment and how to keep people on treatment, and people come back to me and say, but isn't that recovery? I said, no. But isn't that what we always do with other medical diseases? No. It says, there's not a disease that devastates your social structure as much as addiction. So what works? So that would be areas that if I had more money, Sarah, I would be very happy to expand. We're going to start to expand it regardless, because I think that they're very important.
Do you want to jump in?
I add something there that I think ties to one of your original questions around policy levers. There is still work to be done to understand what does the ideal system of prevention, treatment, and recovery really look like. I don't think we have a shared framework for that yet. We know evidence-based treatment is certainly part of it, but the whole system, prevention, treatment, and recovery. But I will point out there are some very easy win policy decisions that are not happening because they're grounded largely, I think, in stigma. One, Medicaid expansion. Science shows improves outcomes for people with opioid use disorder. We don't need new statute for that. That's just the state turning on the lights and being convinced that let's not judge poor people. Let's not have them raise themselves by their bootstraps. Let's make sure they have health insurance. and not make access to health insurance contingent upon whether they can work or not. Step one, easy policy lever. Two, on the criminal justice system, the main reason that, functionally speaking, not just because of stigma, functionally that we don't have treatment in, not just for opioid use disorder, but for diabetes, anything for that matter, any chronic condition, is the Bureau of Prisons is grossly underfunded, and the entire funding mechanism in the Bureau of Prisons does not allow for adequate treatment of patients. Patients will, I think there's a recent interesting article, patients get, people in the criminal justice system will be discharged from the criminal justice system so that they can get medical care and then pop back in and have this recidivism if they don't overdose and die. Judges, like if we direct our stigma education, if we could educate judges who, for the most part, are not informed by the clinical evidence, but are rather making decisions based largely on bias, that's also a massive opportunity. I think if we did those three things, we would be moving, making some real progress.
Can I just add one sentence?
Sure.
One sentence is...
Then we'll go to
yes,
the audience if anyone has questions.
is to pick up on what one thing Andre just said, and then leave prison and die. We talk about thousands, we use the word death, we use about save lives, it's in every article. Just picture being in a cemetery burying a child. That's what we're talking about here. And this can be changed. This is real people, real feelings, real families being torn apart when we can fix this. So I just want to just bring that human element into 100,000 lives, 50,000 lives, it's statistics. This is families.
Does anybody, we have folks with mics who will come around. There's a woman right in the front back, in black.
Hi. My name's Ronnie Solomon from ECRI Institute. Thank you so much to the panel for really advancing this conversation. I mean, it's a really important one. So we are in the midst of all these settlements happening, you know, the drug companies settling up, and what, if anything, are in these settlement agreements that helps put the money where Nora said the money needs to go, or that helps with stigma? Is there anything that's been discussed with them and with the states who are getting some money through the settlements?
I can start with that. There's two aspects of where the money goes. One is, does it go toward addiction or the opioid epidemic in their state? And then if it goes toward addiction or opioid epidemic in their state, is it used for evidence-informed, evidence-based programming? The first issue is the big one. We all know from the tobacco settlement, there was a $230 billion settlement, and 95% of it went to fix potholes and do fix state holes in their budgets, unrelated to tobacco. So the first goal of these settlements is to get the money to be used for this issue. Then, if we can achieve that, then the whole second big thing, does it get thrown into a achievement system that's broken, or are we using it for evidence-based programming? And so the state of it right now, there was one state settlement in Oklahoma, 175 of the $260 million settlement, 175 million went to a foundation that can be used for not just opiate use disorder, substance use disorder across the country. So that's 175, the rest went toward legal fees and to use for local states, local communities, some medication and things in the state. That's the $260 million settlement. But the rest, the $500 million that's coming from J&J, it's going to the state legislature. How that gets used, does it get used for the state budget, or does it get used for the addiction crisis? Up in the air still. First of all, it's appeal, so the money won't come for a while, but when it comes, that's a question. And then is it used for evidence-based programs? So it's a two-step process, and it's yet to be known. We have a policy arm, we're gonna be working very hard, state by state by state. Well, it's one last thing. There's another point of, does a settlement agreement dictate any of that? Or does it go to the state and the Attorney General and the state legislature gets to choose? We are working very hard right now, and so are the plaintiff attorneys, to try to get this in the settlement agreements, like it was in Oklahoma. But to date, it's unknown, because the deals aren't cut yet. So if it's not in the settlement agreement, then you got 50 states that making those two decisions. Does it get used for the opioid epidemic, or to fill the pothole, or to solve their other issues within the state? And then what's used for this? Is it for evidence-based or not evidence-based?
And it's not just the states, the hospitals are now suing, right? So there isn't one settlement. There are lots of settlements that we're going to be looking at over
There's
the course.
2,500, yeah.
Yeah, over the course of years, we're going to be dealing with this. But, to Gary's point, we do not have the infrastructure in place right now to actually provide evidence-based treatment. We need to build the totality of an infrastructure for all the levels of care with the correct kinds of staffing, the correct kinds of modalities. Those are laid out in the ASAM criteria. And this needs to be operationalized because we don't have a system even to pour the money into right now.
Yeah, please, Nora.
Well, to me, we do science in order to guide our policies and to make decisions on how we optimally invest resources to actually, in this case, we want to address is let's contain the crisis, let's revert it. People are dying at extremely high levels. So one of the most ambitious projects that we just launched last year was we basically said we have evidence-based in terms of what works in treatment, evidence-based of what works in the justice setting, evidence-based of what works in the community. But we've never brought it together and integrated in such a way to actually document what happens if we do that. So we funded 4 states that have very high rate of mortality: Massachusetts, Ohio, New York, and Kentucky, to actually do a battery of evidence-based interventions and show that within 1.5 years, they can reduce mortality by 50% and document it, and that actually assess also the sustainability. To the extent that we can learn from this type of implementation science and actually document that this has a dramatic effect on mortality and improves the outcomes on recovery, and that, by the way, it's actually most cost efficient, then we can use data like that to guide, well, if there is a settlement, this guides you. You have a roadmap about ultimately showing you that it can be done.
And if I could briefly add to that, by the time we get that evidence, it's going to take a little while, and I'm very excited for it. The HEAL initiative is fantastic. In the short term, National Academies of Medicine has an opioid collaborative, which we're all involved with, and there are 2 bodies of work that are coming out of it sometime, I think, in the next 6 months. One is, what is the current state of the prevention, treatment, and recovery system? And 2, what is the ideal state of a prevention, treatment, recovery system? That, while it's not the primary intent, can very much be used to inform a judge or inform lawyers of what should these settlements be looking like. So that's something for folks to look into. I'll pause there.
I'm going to take another question. Man in the blue shirt and gray jacket.
Hi, thank you. An excellent discussion, and I think raising a critical issue. I have sort of a comment and then a question. Comment. So I'm Michael Golinkoff. I'm currently the head of innovation at a Medicaid managed care organization. I used to run behavioral health there, as well as at Aetna and United prior. So one comment I wanted to make is that actually health plans, although many things they do are problematic, have, I would guess, I'm going to make up a fact, because that's what we do these days. But I'm going to make up a fact that we probably have done a lot to drive increase medication-assisted treatment, if you give me for the term. Tell me a better one soon. But because we've been pushing evidence-based medicine, and actually our biggest barrier has been the availability of it, and so we've also probably done as much to increase the network by trying to create more, although there are many other things we do that may be counter to that. So I'm not, but I do think that we do play a positive role in that way. One thing I did want to ask you is if you could share your views on privacy, and how it relates to the data. I sort of view it as privacy is almost an institutionalization of stigma, because we think that somehow it's more shameful to share information about a history of addiction than it is around history of diabetes. It leads to people getting much worse care and putting their lives at risk. So I wonder
We're
if you
running out of time, so we'll have one. I wanted somebody to address your question, so how about Dr. Clark address it, and then we wrap up, because We need to get the next panel in here.
So I used to be a health plan doctor, and I am a doctor that's provided care. So I agree with you that the health plans have been trying to increase the access to medications for addiction treatment. That's what I'll use for MAT, medications for addiction treatment. And I will agree with you that there is not an adequate network out there. And as a provider, I will say also as a psychiatrist, the amount of money that is being paid to the doctors to do that work is insufficient for them to take on the task of doing that work. So it's very simple capitalistic construct here, right? We're paying much more for somebody to do a surgical procedure that may or may not be helpful than we are for somebody to do the kind of work that's necessary to actually save a life and the quality of that life.
Thank you, and sorry we had to go.
Privacy. Let's get rid of this 42 CFR piece for interaction of keep it away from law enforcement without a subpoena. But we must all speak together. It's a disease.
Thank you all very much. Obviously, we could go on all day about this topic. Great. Thank you.